We present the case of a 69-year-old woman with a history of chemoradiotherapy and colectomy for rectal adenocarcinoma. The patient complained about mixed urinary incontinence and sensation of vaginal bulge. During physical examination, we found in stage 3 cystocele, stage 1 uterine prolapse, and stress urinary incontinence with urethra hypermobility. After releasing the intestinal adhesions, a standard colposacropexy was initially planned. However, intraoperative inspection revealed rectal adherence to the posterior vaginal wall and extensive fibrosis of the posterior peritoneum with minimal mobility. Given these findings, and in the absence of significant posterior prolapse, the decision was made to place the mesh only in the anterior compartment. The vesicovaginal plane was dissected down to the bladder neck. Thin, poorly vascularized fibrotic tissue was observed. An orifice was then created in the broad ligament, and a polypropylene mesh was fixed to the anterior vaginal wall with 4 non-absorbable braided sutures. The mesh was passed posteriorly through the broad ligament and anchored to the sacral promontory. Because posterior peritoneal mobilization was insufficient to cover the mesh, a continuous closure was performed with V-lock between fatty tissue, sigmoid epiploic appendages, and peritoneum, extending to the right fallopian tube. Finally, a small exposed segment of mesh was covered by advancing the greater omentum and fixing it to the tube. The peritoneum was then closed. The operative time was 105 minutes, with no intraoperative complications. The postoperative course was uneventful, and the patient was discharged after 2 days. At follow-up, she reported an 8 out of 10 of satisfaction, complete improvement in stress urinary incontinence, with persistence of mild urge incontinence,